Kia ora koutou, and welcome to tonight's Goodfellow webinar, COPD Improving Quality of Care. This webinar is supported by Pharmac via an unrestricted educational grant. My name is Pulasti, and I'll be your facilitator for the webinar. I have the pleasure of introducing our two speakers for tonight, Dr. Joe Scott Jones and Professor Bob Hancox. Joe is a GP and Honorary Associate Professor at Te Huataki Waiora School of Health, Waikato University. He is also a Fellow of the World Organization of Family Doctors. Joe has spearheaded projects aimed at improving healthcare delivery and outcomes, for example, helping to develop clinical dashboards on patient management systems. Bob is a research professor at the University of Otago and respiratory physician. He is currently the Medical Director of the Asthma and Respiratory Foundation of New Zealand and a member of the Foundation's Asthma and COPD Guidelines working groups. Supporting Joe and Bob is Catherine Gerard, who is an Assistant Director for Health Quality Intelligence at the Health Quality and Safety Commission, also known as Te Tāhū Hauora. Her role includes supporting health quality intelligence work, and she is also responsible for the National Patient Experience Survey Program. So, without further ado, I'll hand over to our speakers.
Kia ora koutou, ko Joe Scott Jones toko ingoa, and thank you, Pulasti, for the introduction.
Kia ora koutou, ko Bob Hancox Tāhū. I'm pleased to be here for this webinar.
Kia ora koutou, ko Catherine Gerard toko ingoa. I'm just here in the supporting role in case there are any Atlas of Healthcare Variation specific questions, but nice to be here.
And thank you for Pharmac for enabling this all to happen. As Pulasti says, we're going to talk about the Atlas of Healthcare Variation and the new COPD domain, which has been published, and the key findings from that. We're going to focus on some particular aspects of the new the guidelines for management of COPD and give you some things to take away that hopefully will make a difference to your clinical practice. We're going to particularly focus on triple therapy, prednisone, and influenza vaccination rates. So I thought it'd be useful to start with a case. And I think those of you that work clinically will recognize Mr. and Mrs. X who come into your practice. Mr. X rather reluctantly and complaining of breathlessness and cough that he's tolerated for a very long time. A story like this is one that would immediately make me think about COPD. But I would also have on my differential diagnosis list lung cancer for this Māori man in his 50s who's been a smoker for a very long period of time. I'd also be thinking about heart failure in somebody who's presenting like this with increasing tiredness and breathlessness, even though they had no swollen ankles and quiet breath sounds. Often these things can be complicated, and it's certainly those would be the things that would be sort of going through my head. How should I approach that patient?
Well, thank you, Joe. I think I'd agree with your differential diagnosis of common things there. So quite often people would, their first suspicion would be, does Mr. X have COPD? And the guidelines in the current New Zealand guidelines, in fact, all the guidelines in the world really emphasize that we should make a positive diagnosis of COPD using spirometry. So we really should measure lung function. I know that often that's not done. Sometimes it can be very difficult to access lung function in primary care, but we should really be making this diagnosis. We wouldn't diagnose high blood pressure without measuring blood pressure, so we shouldn't diagnose airflow obstruction without measuring spirometry. The criteria for COPD is usually an FEV1 to FVC ratio of less than 0.7 or less than 70%. Some labs are now talking about the low limit of normal, which is slightly preferable on a theoretical basis, but in practice it doesn't make much difference. And these measures are after people have taken a bronchodilator. So if somebody's already on a bronchodilator, you don't need to do the pre and post bronchodilator to diagnose COPD. Just the measurement after bronchodilator should be enough to confirm that the patient's got COPD. Obviously, COPD is not just airflow obstruction. It needs to be in conjunction with compatible symptoms, which Mr. X clearly has. And there's no other obvious explanation for the symptoms. He's not got lifelong asthma or cystic fibrosis or anything else which would explain his respiratory symptoms. And I think, given your concerns about heart failure and lung cancer, it would be sensible to get a chest X-ray at least to exclude those. COPD is almost always seen in concert with a smoking history, but not always. As smoking rates decline, we are beginning to see more and more people with COPD who've really only got a very light smoking history. We believe that they've been exposed to other things, other noxious substances causing the airflow obstruction, but often it's very difficult to know what it is. But some people do turn up with COPD when we don't have a very good explanation. So that's really COPD diagnosis, to encourage spirometry. We're also going to talk today about COPD exacerbations. I'm sure the audience know what this is, but really it's an increase in symptoms of shortness of breath, wheeziness, cough, or increased sputum production or change in the sputum color. These are very often precipitated by infections, but again, not always. We do get quite common exacerbations without any evidence of infection. Sometimes these are eosinophilic. We find that they have high blood eosinophils, a little bit like asthma. That's actually a very useful sign because we know that if they've got higher eosinophils, they're more likely to respond to steroids. So that's quite a useful test to do. But yeah, so sometimes you get infections, exacerbations, sometimes you get non-infectious exacerbations, and sometimes, but not always, they can be eosinophilic. COPD management, this is a very rapid run through the guidelines, which the guidelines run to many pages, but this is really summarizing it in a few slides. The first thing is to be aware of the non-pharmacological management. It's really important to think about these, particularly stopping smoking. It's not too late for Mr. X to quit smoking. It's the most important and the most effective thing that he could do. So it would improve his symptoms. It would stop the decline in his lung function. And it's probably about the only thing that's really known to prolong his life. So quitting smoking remains our number one priority. Managing his COPD, it's very important that he keeps physically active, and ideally we'd refer him to a pulmonary rehabilitation program if there's one available in the area. And I know that that can be difficult to access in many parts of New Zealand, but the gold standard would be pulmonary rehabilitation, and we should try and get him enrolled. We should teach him to manage his breathlessness using, first of all, non-pharmacological means, and we will talk about inhalers in a minute. But there are other ways of managing breathlessness, taking a rest, getting control of his breathing. And sometimes he may benefit from seeing a respiratory physiotherapist who can teach him many breathlessness techniques. If he's producing a lot of sputum, teaching methods for sputum clearance can be very helpful. Make sure that he maintains good nutrition is important. In terms of other things, having a warm, dry house is really important. We're about to come into winter. We know that a lot of New Zealanders live in inadequate housing where it's cold and damp, and we're pretty sure that certainly for children with asthma, having a warm, dry house helps, and we're pretty sure the same applies for COPD. So that would be something else to look at. I put in brackets interventional and surgical approaches. Yes, we do have some interventional approaches which we can sometimes treat people with COPD. They're in brackets because they really are such a small part of COPD management that yes, we should be aware of them, but for the vast majority of patients, they're not going to be appropriate. Okay, so if we think about pharmacological management, this is really about inhalers. we commonly start with a short-acting bronchodilator, such as a SABA, or a short-acting beta agonist, or a short-acting antimuscarinic agent, such as ipratropium bromide. So we tend to start with those, or perhaps an inhaler with both of those in it. But actually, most people with COPD, like Mr. X, should probably be on a maintenance inhaler. And here's our current guideline with basically a table simplifying the current management of COPD. So if you've got COPD and you're not having a lot of exacerbations, from maintenance inhaler, we'd start with a LAMA, or long-acting antimuscarinic. And if needed, move on to a LAMA-LABA combination. If they're having frequent exacerbations, we start with a LAMA, but very rapidly we should start moving to a LAMA-LABA and probably triple therapy with an inhaled corticosteroid as well. And the guidelines are being rewritten as we speak, and the role of triple therapy is going to be emphasized in people who have exacerbations a lot more. There are some people with asthma and COPD overlap. For those people, if you're not sure if it's asthma or you're not sure if it's COPD, you would treat for asthma. So you'd start with an inhaled corticosteroid or LABA, and then you may add a LAMA to that regime if needed. There's no evidence that Mr. X has any history of asthma. It's almost certainly going to be COPD. But if you're not sure, treat for asthma is the main message. Okay, just one slide on a few other things. Don't forget vaccinations. Influenza vaccination, particularly right this time of year, is the time to get influenza vaccines. Influenza is on its way. I understand there are already some cases cropping up, so people should really be getting the flu vaccine. Obviously, you also want people to get the COVID vaccine. Ideally, we'd also like them to have the pneumococcal vaccine, and there's increasing evidence that the RSV vaccine is going to be helpful, but both of those are currently not funded for people with COPD. So unfortunately, unless people are prepared to pay for them, they may not be able to get those. It's also a good time to think about herpes zoster. People with COPD often have a depressed immune system, particularly with lots of prednisone, and so maybe they're at high risk of shingles, and that's also appropriate in this age group. Oxygen, I've also put in brackets. Some patients would need oxygen, but really, it plays a very small part in the whole management of COPD. So it's for very few select patients. We recommend that people avoid long-term or prolonged oral courses of steroids. If you're going to use steroids for exacerbations, try and keep them as short courses as possible. It's not difficult for people to have several exacerbations over a short period of time and then end up with quite bad steroid side effects. So short courses of 5 days are usually enough, and try not to give prolonged courses. We really don't think there's much use for theophylline in most patients anymore. We really, really don't want people to have nebulizers. Nebulizers are not such a good thing. And it's probably not a good idea to mix up a short-acting antimuscarinic with a long-acting antimuscarinic. They tend to be competitive, and if you're starting on a LAMA, stop the SAMA.
Thank you, Bob. Really great rapid overview of the treatment and etiology there. So if you haven't had a look at the Tāhū Hauora Health Quality Safety Commission's Atlas of Healthcare Variation yet, I'd strongly encourage that you do so. Started back 20 odd years ago, and Catherine, congratulations on the vision that was sort of shared at that time of trying to get useful information disseminated out through our system that would stimulate discussion, encourage questions, and motivate us to improve the performance of the health system and improve outcomes for our patients. This is one of the things that really gets me up in the morning, and I really enjoy sort of sharing this sort of information. And the Atlas of Healthcare Variations are really a fantastic initiative, which is sort of very worthwhile exploring. The COPD Atlas indicators were published at the end of last year. The way that these sorts of parameters are developed involves a group of clinicians like Bob and myself and other GPs and specialists getting together and talking about what are the important things that are going to make a difference to outcomes across our communities, and working through the detail of information that is available and then how we would want to display that. And it's a very iterative process that gradually refines a large number of measures down to the 8 measures that you can see here. There's a couple of measures there about prevalence. So really that's trying to get an idea of the disease burden within the New Zealand population of COPD. And then there's the impact of that burden of disease on our hospital system, because that's something that's relatively or easier to measure than the impact in other parts of our system. And then there are some measures around the quality of care based on the guidelines that Bob referred to. You know, that we want people who to be receiving maximum therapy, particularly after they've been in hospital or if they have had a couple of courses of prednisone. We don't want people to be receiving just a short-acting beta agonist. That's not likely to be maximal management for those people, and we want people to be receiving an influenza vaccine. And the Atlas indicators give us a good picture of how that's happening across the country. So I'll hand back over to Bob to talk through the detail of how this is displayed.
Thanks again, Joe. And one of the questions we quite often get asked at the Asthma Foundation is what's the prevalence of COPD in New Zealand? And it's an extraordinarily difficult number to estimate. There just aren't widespread studies of using spirometry in the population. So the Atlas estimated that about 66,000 people had COPD in 2023. And we identified that by anybody being admitted to hospital with a diagnosis of COPD. So I think if you get discharged from hospital with a diagnosis of COPD as a label, I think we can be fairly confident that you've probably got COPD. The other way is by anybody who was dispensed a long-acting antimuscarinic, so a LAMA. So if you have a LAMA, in theory, you should have had your prescription endorsed by the fact that you've got COPD. COPD is the only current indication or pharmac indication for a LAMA. So anybody who has had a LAMA should be diagnosed with COPD and ideally should have had spirometry. It's a messy measure, but it's what we've got. Now, obviously, this will undercount people with COPD who have COPD who are not using a LAMA, but like I say, it's as good as we can get. We selected age 45 years as the minimum age of cohort. Yes, you can get COPD before the age of 45, but it's unlikely. And actually, 98% of those people estimated to have COPD by our measures were over the age of 45. And like you can see on the table on the right, that amongst young people, there's a small number of people with COPD. I suspect most of those have got other diseases rather than what we tend to think of as COPD. The denominator that we used was those enrolled in a PHO. And there were only less than 1,000 people who were identified as having COPD who weren't enrolled in a PHO. So that's about 1.5% of the cohort. So I think we captured most people with COPD by those two criteria. One other thing to notice is that the ethnicity is a total response. So somebody identified as Māori and European, and then got included in both of those ethnicities. So here's the age distribution of those admitted with either asthma or COPD. And I don't think there are any surprises there. It's an interesting thing. If you look on the left, those admitted with asthma were far more likely to be young people, and the admissions for asthma are mostly in the children and some young adults. But there was a smattering of asthma admissions all the way across the age range. Admissions for COPD were almost exclusively the older population, you can see in the red. Here we have COPD in prevalence. This is just amongst the PHO enrolled population aged 45 years and over. And I think the colors hopefully come out, but the top line rising between 2018 and 2023 is Māori. The bottom line in yellow is Asian, and Europeans and Pacific group, two lines are parallel to each other in the middle. And I think you can see that there's a massive disproportionate number of people who have COPD among Māori, much higher, twice as high as Europeans and twice as high as Pacific. For reasons which maybe we can discuss later, Asian people appear to have a much lower prevalence of COPD. I was going to say, you'll just notice that the lines have been going up between 2018 and 2023. Now, that could be due to an true increase in prevalence, but it could also just be due to more widespread use of LAMAs. So maybe we're just getting better at prescribing these people LAMAs. The prevalence of COPD by age and ethnicity, according in the PHO, we've got divided into 3 age bands: 45 to 64, 65 to 74, and 75 and over. And you can see, as you expect, the prevalence is much higher in the 75s and overs than it is in the younger age bands. But you'll also see that the prevalence is among Māori is at least double in each age band. So Māori have a very high prevalence of COPD compared to European others. Pacific people have slightly higher prevalence of COPD, but certainly not as dramatic. And as we said before, Asian people appear to have a low prevalence of COPD. Now, this is where it gets very interesting, and I would be very interested in people's thoughts about this. This is looking at the COPD prevalence amongst PHO enrolled populations, again, restricting this to age 45 and over. And you can see that the different, what used to be DHBs, have huge differences in prevalence. So on the left, we have, in the light blue, we have DHBs who have less than expected. The New Zealand average is in the middle, and then on the right are DHBs that have a higher prevalence than expected. And you can see this, comparing, say, Auckland with on the far left with Wanganui on the far right. It's a massive difference in prevalence of COPD. If you look more carefully, it seems to be that the major centres tend to have, so Auckland, Canterbury, Capital and Coast, Waitemata, tend to have lower prevalence of COPD, and some of the more rural areas, Wanganui, West Coast, Tairāwhiti, Hawke's Bay, tend to have a higher prevalence of COPD. But we don't really have a good explanation of why this is, but that's certainly something for further investigation. And this is looking about COPD prevalence in Māori. And again, we see a massive variation between prevalence of 4.5 to 9.2, so more than double the prevalence in Wanganui compared to Canterbury. Again, not really obvious why. You might look at the graph and think, well, some of the more rural areas on the right and some of the larger centres on the left, but we don't really have a good explanation of why the prevalence varies so much. Is it a different exposure to risk factors? And as we said, the main risk factor is smoking, but we're not quite sure. Okay, so now we're looking at people who've been admitted to hospital at least once with a primary diagnosis of COPD. Now, the denominator here is of the enrolled PHO population. So this is the rates per 1,000 population. And again, it's divided into 3 age bands. So the younger age is on the left and the older age is on the right. And you can see that the number of people, or the proportion of people from the community enrolled in a PHO admitted to hospital with a diagnosis of COPD is much, much higher in Māori in all age bands. So even amongst the 45 to 65-year-old group, 5.6 per 100,000 were admitted to hospital with a diagnosis of COPD, and that rises up to 23 per 1,000 of those in the older age groups from Māori. Much, much lower rates in Europeans, and in between rates in Pacific people, and low rates in Asian people. So Māori were about 3 times more likely to be admitted with COPD than a European other. This is a similar information but presented differently. This is the hospital admission rates for those who we believe to have a COPD diagnosis. So this time the denominator is among those who have COPD rather than amongst all patients in the PHO. Again, we can see that the numbers rise with age, although not quite so dramatically. And we can also see that Māori, and in this instance, Pacific people, have higher rates than Europeans and Asians. But actually the difference is not so stark. The differences between Māori and Pacific and European others being admitted to hospital are there, and they're not trivial, but they're a much less different. The differences are much less than when we look at the PHO population. So this the increased rate of admissions among Māori and Pacific are largely explained by the increased diagnosis of COPD, so higher rates of COPD. And still suggests there is a lot of quality to be gained by better treating some sections of our population to try and prevent hospital admissions, but the differences are not quite as stark as when we look at the whole population.
Thank you, Bob. So if you look at the Atlas of Variation, one of the pictures that you'll see for your particular area will be this one, which is a way of displaying the information in a visual way. The pink line it will be your local area, the grey your local district, the grey area, or the district you select, and the grey area is the New Zealand average. The size of the circles for the male and female will change depending on the proportions of those, and you'll see graphs that sort of change over the year. This is the national data for those people aged 45 and over with COPD who were regularly dispensed triple therapy. In the COPD Atlas, the definition of regularly dispensed is at least 2 out of the last 4 quarters. So 2 quarters in the last year. The reason for that is that sometimes people do minimize their use of their inhalers. So we determined that a regular dispensing 2 out of 4 quarters would be the minimum that we would expect for somebody who was being treated reasonably well. So let's have a little think about some of the standards of care and see what the Atlas of Variation can shine a light on, whether we're actually treating people in the way that we perhaps would like to in an ideal world. So in the 12 months after a hospital admission, the guidelines would recommend that people receive triple therapy, the LAMA, the LABA, and then inhaled corticosteroid. And that should be considered really seriously for those people. And we can see that it's around about 60% of people, with a little bit of variation across the age groups, a little bit of variation across ethnicities. Around 60% of people receive a regular triple therapy following a hospital admission. Does that seem right? That there's 40% of people that are not getting that. That makes me think, does that feel right to me? If we think about those specific people who are more likely to be admitted than European and others, why is it that they seem to be getting maybe slightly less access to triple therapy than others? Is that happening in my practice? Is it happening in your practice? Is that something that I should explore a little bit more? Another aspect of the guidelines is emphasizes that if people are receiving 2 or more courses of prednisone, and they should be regularly receiving triple therapy in the following 12 months, because repeated course of prednisone would suggest that they've got poorly controlled COPD. Again, the question that this data sort of raises for me is 70% of people who have had 2 or more courses of prednisone, only 70% of them receiving triple therapy. Does that feel about right? Am I perhaps doing this in my practice? Does this make me want to think about looking into that and maybe sort of reassessing when I have somebody who's a little bit unstable with their COPD, they've had a couple of courses, should I think more seriously about getting them onto triple therapy? When we look at the variation across the districts in receiving triple therapy in those 12 months following a hospital admission, this is for the cohort of people aged over 65 to 74 years, we don't see a lot of that variation across all of the districts. So that makes me think that this is a systematic issue. It's the same issue is going to be impacting across all of the districts. So it's not something that's specific to where I live or to the services that are available in my area. And similarly, for those people who perhaps ought to be receiving triple therapy in the 12 months after they've had 2 or more courses of prednisone, there's not a lot of variation across the districts. So again, is this a systematic problem that we have as a population of health providers? Is there something systematic that's happening for our patients that is causing across the whole country this not to be being applied, not being achieved? So the COPD guidelines again emphasize that when people are getting repeated exacerbations, that dyspnea, wheeze, cough, sputum, it's usually treated with prednisone and antibiotics. But if they're getting repeated exacerbations twice or more a year, they should be elevating to a long-acting beta agonist, a long-acting muscarinic agent, and then they have corticosteroid therapy. Particularly if they've been adhering to their dual LABA or an ICS and LABA therapy, and using their inhalers the way that they should be doing. And for those people who are getting severe or recurring exacerbations, we should be thinking about putting them, directly onto the dual or triple therapy. So again, the Atlas of Variation can shine a light on another aspect of quality of care, the access to influenza vaccine in people with COPD. And we can see that for those people, the top line are those who are 75 and plus, the middle line 65 to 74, and the bottom line for those people with COPD age 45 to 64. We can perhaps see the impact that we've seen in other immunizations following COVID in a trend downwards since 2020 in these figures. But for those younger people with COPD, they don't seem to be getting access to the influenza vaccines in the way that people over 75 do. But all of the cohorts is falling over time. When we look specifically at different ethnicities and at different ages, we can see, again, quite considerable variation, particularly in those people over 65, with Māori receiving less influenza vaccine than other ethnicities. There's quite a lot of variation in this across the districts. It was Te Tairawhiti who have the lowest access of influenza vaccine for people with COPD at 22% of those aged 45 to 64. And again, when we look at the atlas, it sort of stimulates us to sort of think, well, is that right? What are the barriers? What are the things that are really triggering that to be happening? And then, of course, what can we potentially do about that? Why is this important? Well, because the influenza vaccine reduces the risk of hospitalization between 22 and 43%, depending on which studies that you may look at, and it certainly reduces exacerbations of COPD. Moving on to another aspect of the atlas, we started to look at rurality using the geographical classification of health that has been developed by the University of Otago in particular, but a sort of team of rural clinicians from across the country. Those of you that live rurally will be becoming familiar with these maps, which show those 5 geographical definitions or regions that New Zealand's been broken down into, and where the most urban, moderately urban, moderately rural, more rural, and then remote rural. The most remote rural being dark green, and urban being in the dark brown. So these are based on where people live, and it's based on their access to health services, which hospitals in particular that they have access to, and the services that they have. So if we look at our COPD and look at how things vary for those people living in our rural populations, we will see that the prevalence, as we've seen in the other graphs, is lowest in the most urban category, and highest in the rural 2 and rural 3 in the most rural categories. If we look at that by ethnicity, it's interesting to see that the prevalence in the bottom graph on the right-hand side, the dark block that you see there on the left-hand side is the most rural category, the R3s, and you'll see that for Māori, they seem to have the lowest prevalence in the most rural areas. And we think that might be a reflection of access to care. So remembering our definition is those people who've been admitted to hospital and those people who are using a long-acting muscarinic agent. So perhaps where we would expect this to be much higher, perhaps this reflects less access to care, less access to hospitalization. If we look at the European and other, we have the lowest prevalence in our most urban communities, which is what is reflected in the other data. when we look at rurality and the how we're managing care or people getting access, there isn't any significant difference in triple therapy in the year after admission or in those in the dispensing of triple therapy following 2 or more courses. But again, Māori have the highest prevalence irrespective of their rurality. If we look at vaccination rates, again, perhaps reflecting access to care, what we see here is that those people living in the rural 1 and rural 2 and 3 have lowest access to or lowest access to flu vaccine, and Māori again are consistently lower across all communities, but particularly in rural communities. So I'll hand back to you, Bob.
Thanks, Joe. So we've shown the data that we're going to show. There's more details that will be available if you actually access the Atlas online. But there's some things come out of this that we perhaps should discuss. So about 4 out of 10 of those admitted to hospital with a primary diagnosis of COPD did not regularly receive triple therapy in the following year. So I think really we think that people who come into hospital with COPD have had a severe exacerbation. They should really be on triple therapy. We appreciate that there are some loops to go through in terms of getting triple therapy and diagnose it from Pharmac, but actually the evidence is that triple therapy reduces exacerbations and improves airway function. And we think that most of those people should be treated with triple therapy now. You can do a special authority and you can get the triple therapy now in a single inhaler. There are two varieties of single inhaler out there to choose from, depending which the patient prefers. So I suppose in terms of quality improvement, we would like to see that number who don't get triple therapy diminish. Also, 1/3 of those who had 2 or more courses of prednisone. So these are people who are having recurrent exacerbations bad enough to go and get prednisone, didn't get triple therapy. And again, these are a group of people we think should be getting triple therapy. And repeated use of prednisone without triple therapy is probably an indicator of suboptimal management of their COPD. The third thing is the influenza vaccination rates are much lower than we would like. They do get better with age, so older people are more likely to get influenza vaccine. But even in every age group, it's lower than we would hope. Influenza is very useful to reduce the risk of COPD exacerbations and reduce the risk of hospitalizations. We know that the influenza vaccination rates are lower in the rural community and were lower in Māori, so that we've got some work to do. I know there's a lot of vaccine hesitancy out there. It's not necessarily what is being offered by health professionals, but we have some work to do to improve vaccination rates to flow. So, take-home messages. Prevalence of COPD is highest in Māori and Pacific people, but varies vastly from one district to another, even with age-specific rates, and even when we divide by ethnicity. Admissions with a primary diagnosis of COPD are highest amongst Pacific people, and they also have the lowest rate of triple therapy. Of those admitted, only about 60% receive triple therapy in the year after admission. Is that high enough? I think from what I've said on the previous slide, you'll realize that I don't think so. And I also don't think it's high enough that 70% of those getting 2 or more courses of prednisone receiving triple therapy is high enough. Flu vaccination, we need to do better. We are doing a little bit better on older people, but we still need to focus on, particularly on younger people with COPD, to try and reduce their risk of exacerbation and reduce their risk of hospitalization.
we wanted to give people some skills for Monday. There's some links here to well, I'd encourage you really strongly to look at your community health pathways. Your local community health pathways may not have been localized for COPD, but I can guarantee you that there's a really useful view of COPD management accessible to you through community health pathways. Obviously, we've talked about the COPD guidelines that Bob and others have been really instrumental in writing and developing. And as he's hinted, they're in the process of being reviewed and revised at the moment. But it's definitely worthwhile having a look at the current guidelines. I gather they're not going to change hugely with the reiteration, Bob.
I don't think so. And certainly not what we've talked about isn't going to change very much. There probably will be even more emphasis on the importance of triple therapy and people having exacerbations and hospitalizations. The flu vaccination recommendation is not going to change at all. But the new set of guidelines should be available by the end of the year.
And the other thing, which is a brilliant tool, the BPAC prescribing tools that we've got a link to there. So that basically sort of steps you through what the next choice of inhaler type should be for you, depending on whether this is a new diagnosis of COPD or somebody who's got COPD and they might be sort of starting to suffer some exacerbations. So it can be quite confusing with all of the different types of inhalers that are available, and that prescribing tool really sort of steps you through it. I think that's fantastic. We have to mention the Goodfellow unit course on COPD. It doesn't take too long to do, and it's really great. Some of us, hand up, have to do the quiz at the end several times in order to get 100%. But that's a good reflection that it's a very useful sort of course. And of course, then there's one of the messages we want to take away, and particularly from the Atlas of Variation as a whole, is this reflective practice, understanding our own practice, the way that we work. Your PHO might be providing you with a dashboard that's shining some light on respiratory management. You might be able to run some query builds and audits within your own practice to reflect on some of the aspects of management that you've heard about this evening, and just take that little step back and think, when you have a patient in front of you, particularly someone who's Maori or Pacific, ask yourself, am I treating this person in the best way that I possibly can? Is there just take that little bit of time to overcome any internal biases that might be sort of playing some part in prescribing, thinking about the people with exacerbations, people who've come out of the hospital, and maximizing their therapy. So we had a few questions that we thought might be raised, but we're really open to questions from the floor at this point.
So one question that was asked quite early on in the presentation was around vaping. Are you aware of any evidence coming up that vaping is a risk factor for COPD? And I think also a lot of people are turning to vaping when they quit smoking. For example, their GPs told them to quit smoking because of their COPD. Is there any risks for them continuing to vape if they've already got an established diagnosis of COPD?
That's a very, very good question. I wish I knew the answer to that. It's just too early to know. I mean, smoking, you have to smoke for many, many years before you develop COPD. And vaping just hasn't been around for long enough. We certainly know that it can be irritant to the airways. There's increasing evidence that vaping can be irritant to the airways, and so it's likely to cause some bronchitis. But whether it actually causes COPD, we just don't know yet. If I have a patient who's quit smoking completely and has managed to do it by vaping, well, I'll take that as a win, because it's unlikely that the vaping is going to be as bad as smoking. But that's maybe the difference between being hit by a bus and being hit by a car, It may it's probably not as bad, but it's not great either. I worry about people who have quit smoking and vape, and so they're doing both, because we really don't know what's going on. They're still smoking, maybe less than they were, which is a win, but now they're vaping as well. And I just don't think we know. I mean, it's going to be, I think, years before we know. I am really worried about a new generation of young people becoming addicted to nicotine, and 20 or 30 years time, we may know the consequences, but we just don't know right now.
Can we diagnose COPD on a chest X-ray? And I wonder if that's come across because of issues with accessing spirometry to get a gold standard diagnosis.
The answer is no, you cannot diagnose it. Chest X-ray might be useful for looking for other diagnoses. And I know chest X-rays often get reported as saying it shows COPD changes. It's not good enough. It doesn't diagnose it. So sometimes you'll have an X-ray with a report like that and the spirometry be completely normal.
And I think just the pragmatic response is that somebody who's got a clinical story that fits with COPD, whilst you are trying to get them to access the spirometry, start them on the inhalers, start them on the pathway anyway. You can't do anything else.
You mentioned earlier in the presentation about asthma COPD overlap. So someone's asked, is smart therapy ever appropriate in those kinds of situations? As in having their Symbicort, is it still safe for them to keep using extra doses of Symbicort during the day?
There's very little evidence on smart therapy for COPD. I'm aware of one small study which suggested it may be okay, but it was too small to show any real evidence. I think if you think they've got asthma, and asthma is a predominant problem, then I think it's perfectly reasonable to use smart therapy or air therapy for those people. The concern mostly with asthma COPD is that if we just treat the COPD, we'll miss treating the asthma. So I think if somebody's got asthma COPD overlap, you're really not sure, and you think they would do well with smart, then I think that's fine to try it. Using smart for COPD alone, we just don't have enough evidence to recommend it or not recommend it. We don't know.
And I guess I have a follow-up question. Let's say the smart works really well for the asthma, but then would we be concerned about the increased pneumonia risk if they are having extra doses of an inhaled corticosteroid through their Symbicort?
Yes. I mean, one of the worries about people with smart therapy and COPD is that because COPD lung function is less responsive to bronchodilators, then they will use more and more and more and more of it and could take a lot of inhaled steroids. The pneumonia risk is there. By and large, the pneumonia risk is quite small compared to the benefits you get from standard doses of inhaled corticosteroids. So I think you'd have to pick your patient. If you've got somebody who's going through a canister of their salbutamol every 2 or 3 days, then putting them on smart, and it's mostly COPD, putting them on smart therapy may not be such a good thing to do. If you think it's primarily asthma and is responsive to bronchodilators, and I don't think you need to measure lung function response to bronchodilators, it's symptomatic response to bronchodilators, and you think there's definitely a component of asthma that I think it's reasonable to try smart. But it's a little bit of an evidence-free zone.
You did mention sort of early in the presentation how we want to avoid frequent uses of oral steroids. So someone has asked, well, do you have any recommendations of an ideal regime to manage exacerbations? I guess would we be preferring shorter duration, lower doses, or is it better to hit them hard with a higher dose and get on top of their symptoms?
I don't know what you do, Joe, but what I do is 5 days of 40 milligrams a day. That seems to be the standard practice. Occasionally, I will extend it at a lower dose. I'll give them another few days of say 20 milligrams if things are really slow to respond. But usually 5 days of 40 is enough, and I try not to extend it beyond there. So I think that's a fairly standard regime. Joe, do you have any thoughts?
Yeah, I mean, I certainly endorse that and try and stick to that, and then and also trying to reduce my courses of antibiotics as well. If I think that's an infective exacerbation, then I'm trying to stick to a 5-day course of antibiotics as well. Which is for GPs of my generation is a bit of a mind change. We used to give 10 or 14 days worth of antibiotics for a course, but it's I think that combination of short courses, relatively sharp, seems to work better.
Yeah. I'll just add one caveat to that, is that quite often there's a lot of bronchiectasis in New Zealand, and quite often that's not recognized. So if somebody's having persistent purulent sputum, then we should have a high clinical suspicion for bronchiectasis. And that's, if somebody's has an exacerbation of their bronchiectasis, that's probably the one occasion when we do recommend prolonged courses of antibiotics up to 2 weeks of antibiotics for bronchiectasis. So that's not really COPD, but often it will be difficult to distinguish between COPD and bronchiectasis sometimes.
Hopefully you might pick it up on a chest x-ray that you might be doing as part of sort of a routine assessment for a long-term smoker.
You might do. Ideally, for bronchiectasis, you want to diagnose on a CT, but that raises more access to care and probably referral to specialist opinion and stuff. So, yeah, I realize that's challenging.
One attendee did ask why you recommend avoiding nebulizers.
There's no evidence that nebulizers are better at bronchodilation than using an inhaler and a spacer. They deliver, a standard nebulizer will deliver equivalent of 50 puffs of salbutamol, which has a whole lot of side effects. Causes lactic acidosis, causes tremor, causes tachycardia, makes people feel anxious, makes people feel worse. So although it may make them breathe a little easier, they often get anxiety associated with that. It makes people feel very dependent on the nebulizer. A nebulizer is a lot less portable. So if every time they get bad, everybody rushes to put them on a nebulizer, then they develop this psychological dependency. Well, if I get bad, I must have the nebulizer because that's what they do at the doctors. And all of this for no evidence that it does anything better. There are occasions when we have no choice but to use a nebulizer, but I virtually never prescribe it to be taken at home. I think nebulizers are sort of emergency department level treatment. COPD should be well controlled. You should be able to manage with an inhaler and a spacer.
Just for purposes of defining a frequent exacerbation, so we're saying 2 exacerbations per year, we define as frequent. So that's when we need to start thinking about adding inhaled corticosteroids, for example.
More than one. Anything more than one.
More than one, yeah, sure. Yeah. And there's another question about how quickly you should be escalating from, say a LAMA to a LAMA, LABA, and then further on. I guess they're probably asking how many weeks should someone be established on one before you then move on to the next one?
Well, Pharmac, who I realise are sponsoring this, say we should trial a LAMA first, but they don't actually say for how long. So I think it depends on the patient. If you're pretty sure that they're going to require more than just a LAMA, I think you can escalate very quickly. I don't think there's any set number of months or weeks that you have to wait. I guess if you try a LAMA and they get miraculously better and they're fine, then you've done the trial. But I don't think you need to wait for weeks.
There was a question around, obviously we're saying that anyone who's been discharged from hospital, anyone who's been hospitalized with a COPD exacerbation should be on triple therapy. So a few of the attendees, I guess from the primary care background, were wondering, are the hospitals discharging patients on triple therapy in the first place?
That's a good question. I don't know.
Not in my experience. So it is something that we do. It would be great if there are some people discharging from hospital who are attendees at the webinar, sort of could take that on board. But I think we're all in this together, and it's all about the patient. And if our patients are coming out of hospital and we see that when we're doing a medication review, would they're not on triple therapy, then let's think about that. But it's about the patient.
And then a couple of questions around when we should be stopping inhaled corticosteroids. So after, say, a year of post their hospital exacerbation, if there are no more exacerbations, is it fine to then say de-escalate them down to a LAMA-LABA combination or something even less? Is that an appropriate de-escalation pathway?
Yeah, I think so. If there's no evidence that there's any benefit, then maybe think about it. If they've had an episode of pneumonia, we know that inhaled steroids do slightly increase the risk of pneumonia. It's not a big increase, but it's still a nasty disease to have. So maybe think about it then. If they're still having frequent exacerbations, I would be reluctant to stop the inhaled steroids. If they have any evidence of raised eosinophils, and when I say raised eosinophils, I don't mean above the normal range on the printout from the blood count. I just mean eosinophils that ever go up above 0.3, or and other people argue maybe even a lower level than that. But if there are measurable eosinophils towards the upper end of the normal range, then they're probably going to be more responsive to inhaled steroids. So we wouldn't recommend it, or we wouldn't recommend you stop the inhaled steroids. If you feel you need to, you do it cautiously. And you should always review the person after 2 or 3 months just to make sure that they haven't deteriorated when you withdrawn the inhaled steroids.
Sure. And sorry, just to clarify, if they were to say have a pneumonia while they're on triple therapy, would that be a concern and you'd want to stop the inhaled corticosteroids?
I would think about it. I wouldn't necessarily do it. I would give it some thought, and I would look at the other things. Have they had multiple exacerbations beforehand? Do they have raised eosinophils? Is the history suggestive of asthma as well as COPD? There's a number of things I would take into account, but I would think about it, but I wouldn't necessarily do it.
And there were a couple of questions around eosinophil counts as well. So would it be fair to say if someone does end up in hospital with a flare of COPD, whether they've got a normal eosinophil count or not, triple therapy is the recommendation there?
Yeah, I think so. I mean, so if somebody's having recurrent exacerbations or at least one severe one, we would treat with triple therapy. The difficulty about eosinophils, they are great. I mean, eosinophils are quite useful as an indicator. The difficulty is they vary. So you can have one exacerbation which has got no eosinophils, and the next one have high eosinophils. So if somebody's had multiple blood crests over many years and you can see they've never got any eosinophils, maybe that would make you think twice, do they really need inhaled steroids? But very often they will have another exacerbation and it will be eosinophilic. We see this with asthma. A colleague of mine did a study in Canada and looking at people who've had 2 admissions for asthma, and 50% of the time they change between eosinophilic and non-eosinophilic. So whatever they were the first time, the 50% chance that they weren't going to be the next time. So maybe we don't see quite the same variation in COPD, but we certainly do see a lot of variation. So yeah.
There's also a question around, I guess, looking at higher risk population. So would you have a low threshold for starting someone on triple therapy if they were, say, Māori or Pacific heritage compared to non-Māori, non-Pacific? Is that ever a consideration in terms of escalating to triple therapy?
Not on its own, I don't think, but I think there are a number of things you would need to take into account. Acceptability of the inhalers is really important. Patients' understanding, and I should have put it on the slide when we talk about the guidelines. And education and patient understanding is the key to everything, and patient acceptability. And so I think you have to take all those things in context. Access to care, how easy is it for this patient to come back and see the doctor? Are there lots of financial barriers to coming to see you? So I know that people out there in primary care take all these factors into account probably every day. But I wouldn't, on ethnicity alone, I probably wouldn't change the treatment, but I would be aware, say, for example, that Pacific patients appear to be treated less well, and you think, for the individual patient in front of you, you think about what about their access to care. Joe, maybe you can expand on that.
Yeah, I think one of the things that I do, and this is from implicit bias training, if I have somebody who is Māori or Pacific in front of me, I do, as I said, and just sort of stop and remind myself that people from Māori and Pacific populations, for whatever reason, get less access to standard treatment than other people. And so just reminding myself of that can help me to reduce the impact of that implicit or unconscious bias that I might be bringing into the room with me when I have a Māori or Pacific patient in front of me. Same applies for people from all sorts of different populations, but you do just have to sort of stop and make a conscious decision. So it's not necessarily about increasing access, which we saw really successfully with diabetes medications. Having a pharmac increased or had a pro-equity approach to the novel diabetes medications. We saw an appropriate increased uptake for Māori and Pacific of those medications. Not necessarily that for the COPD management, but it is just stopping and thinking and addressing any sort of implicit bias that you might have as part of that as well.
There's also a few questions around either starting an inhaled corticosteroid on someone who's on long-term oral steroids versus, or the other way around, someone who's already on a long-term inhaled corticosteroid. Is it still safe for them to be given a short course of oral steroids for an exacerbation? Just want to check what your thoughts are on that.
Yeah, I don't think there's any reason to, if somebody's on a long-term inhaled steroid and they need a short course of oral steroids, just treat them normally. I wouldn't stop the inhaled steroids. All you're going to do is cause confusion, and the amount of inhaled steroid on top of the oral steroid is trivial. So in terms of systemic side effects, so just carry on the inhaled steroids if you're prescribed oral steroids. The other question is, somebody's on oral steroids, adding inhaled steroids. Well, people on oral steroids, we would love to get them off it if at all possible, or at least minimize the dose. And anything you can do to reduce the dose of oral steroids, it should be done. And if that involves giving them some inhaled steroids, that's great. Just do it.
Do either of you have a favorite device, delivery device that you prefer for your patients?
The one that works and that they accept. I think that's the most important thing, is the one that people are going to use. And that's sometimes a question of trial and error.
Yeah, I would agree with that. The one that the patient will use and the one that they prefer is going to be the most effective. It is worth pointing out that dry powder inhalers, if all other things are equal, dry powder inhalers have a much less environmental impact than spray metered dose inhalers. So in terms of global warming potential, they're much lower. Whereas and patients are actually willing to have that discussion mostly, and so that may be one other thing to throw into the mix. It so happens that both of the options for triple therapy in a single inhaler or dry powder inhalers. So it's whichever one they will use.
There are a few questions around special authorities as well when we're wanting to escalate. Is there, hopefully I'm not opening a can of worms by asking that question, is there sort of guidance or a kind of a summary you could give just for those watching in terms of how they should be thinking about when they need to start thinking about applying for special authorities to then escalate, what the kind of rough game, the rules of the games are?
I mean, I think they're fairly straightforward. I mean, I don't have them in front of me, but for, say, the triple therapy in a single inhaler, you have to tick a couple of boxes. They've got COPD confirmed by spirometry, or spirometry has been attempted, but there are a small number of people who just can't do spirometry. But there is that take that option if you just can't do spirometry, that you can tick that box. And they've been on the separate inhalers before. And just following on the box, I think most people who've had severe exacerbations of COPD, who've got confirmed COPD on spirometry, I don't think it's a huge challenge to get them. Joe, your thoughts?
No, just echo what you're saying. I think it's I think the first thing to do is to think about the medication. Just because there's a special authority, don't let that be a barrier to you making that choice. And then I think the criteria, they're relatively straightforward.
Any advice you have around antibiotics you would use in acute exacerbations of COPD, assuming assuming you think that there is an effective cause for it, of course, clinically.
Yeah, well, certainly for me, my first protocol is amoxicillin, and the doxycycline, my second protocol. I must say that I tend to refer to the antibiotic guidelines that are available through health pathways, because that's one way that I can really make sure that I'm keeping up with the latest guidelines that are coming from people like Bob.
Okay. I tend to see people, because I'm working in a hospital, I see people who have been admitted to hospital. So I tend to use Augmentin first line, because it will cover slightly more than amoxicillin. Very often the people who come to me have already had been started on the antibiotics by their GP, and I'm thinking I need to broaden the spectrum slightly. But I'm not. I can, with Joe, go with your local antibiotic guidelines, and if they're not allergic to penicillin, amoxicillin is a good choice.
Right. Well, we've reached the end of our time allotment. Thank you again so much for our speakers, and also again Pharmac for providing the grant that funded this webinar. Hope you all have a lovely night, and we'll see you at our next Goodfellow event. Thank you so much.